Bye. Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken. This is your one-stop shop for all things eyeballs. Some of you, I learned, like to listen to these episodes at night as you're drifting off to sleep, letting the slow droll of my comments about eyeballs just lull you to sleep in an ASMR type of. I've been told I have a bit of an ASMR quality to my voice, a timbre, whatever the right word is for it, tone. I don't know. Anyway, however you listen to me, I'm glad you're here because I've got some fun things to talk about. We're gonna keep it light. And by that I mean I'm not gonna. There's like a lot of terrible things going on in healthcare, as there always are. But we're gonna save those for another day. All right, let's just have a good time because I want to do a deep dive on cataracts. I want to talk about cataract surgery. I want to talk about the history of cataract surgery. In fact, on the recent episode where I talked about my ideas for having a blood drive at the Renaissance Fair around the country. Somebody, I got a comment on the YouTube channel from @EmbersAssembling939 said, since humans have done rudimentary cataract surgery for more than 2,000 years, could you do a run through of ancient cataract surgeries? So I'm going to do that. I'm going to talk about cataract. I'm going to talk about the lens. I'm going to talk about the anatomy of the lens. I'm going to talk. It's one of my favorite parts of the eye because it's what I do the most of, which is cataract surgery. So I cannot wait to talk to you all about that. But first, a couple things. One is I hope you're all enjoying my series that I've been doing as frequently as I can. It's hard for me to sometimes, life gets in the way of me recording content because this is my second job after all. Plus or minus a third job, depending on what you consider like being a husband and father. So a lot of jobs. But anyway, I try to do the videos as often as I can. Sometimes I'll go a couple weeks where I just don't have time. Sometimes I'll just be able to fire off a few real quick. But anyway, one of my favorite things right now is this series I'm doing where I use a random number generator to generate a number between 32 and like 697, because that's how many pages there are in first aid, USMLE first aid. So I use a random number generator, get a number, and I turn to that page, and then I have to make a video about something about a disease or an anatomical structure or some kind of physiology of some part of the body. Whatever's on that page, I got to make a video, an educational video about it. It's a challenge for me, which is part of the fun. I needed something to spice up the creativity a little bit. I've been doing these videos now. I've got like 500 videos. I've been doing it for 5+ years. And so I needed something new. And this has been really fun. But most recently, I published one about, I turned to the lysosomal storage disease page. Wasn't real happy about that. But I got it done. It was actually a fairly popular video. People liked it. But what I realized, though, is that I think I'm learning more trying to like spend time making jokes out of like learning these things. In the process, I personally have learned more about lysosomal storage diseases just making that video than I ever did in medical school. And it's like, I'm going to remember some of these things. It's like encoded in my long-term memory. I don't know. There's something about humor, about comedy. It's like there's this neuron pathway between the memory part of your brain and whatever part of your brain makes you laugh at stuff. I have no research to back this up. This is all conjecture, but I feel like there's something there. So maybe you researchers out there can help me out. Is there a connection? Like, there's a connection between memory and like sense of smell and, right? There's things that jog your memory. Well, is there something about like, I don't even know what part of the brain makes you laugh. Like, where's the humor part of the brain? I feel like maybe I should know that, but I don't. But somehow I now know more about lots of random things about the human body than I never did before. Maybe I did at some point, I just forgot them, but either way, it seems like laughing at something, making something humorous really helps you remember it. But that's just me. And I'm like, I have to spend a lot of time writing these skits, right? And I'm thinking about the fact that, Gaucher's disease is caused by glucocerebrosidase. And how do I make that funny? So it's a I think I spend more time thinking about it than other people do. So I'd be curious if you guys, all my listeners, are have find the same thing. Like, do you feel like you actually like kind of learn a little bit from these things? Because in the end, I'm trying to entertain you, right? I want you to be entertained, but it's kind of fun if you learn something like along the way. So anyway, let me know. I'm still having fun. I've got like roughly 730 pages to go in first aid, and there's like multiple topics on those pages. So I'm going to be at this for a while until I get it to where you can pass your boards. So it's stay tuned for more of those. I've got some more to do. Okay, so what I thought we could do also before we get to our eyeball topic of the day, which is the human lens, not the animal lens, not the cow lens, not the dog lens, the human lens, is talk about 4th of July. I hope everybody had a great 4th of July. Uh, at first, I thought, I could do like an eye trauma thing or about the 4th of July. I've touched on all the eye traumas over the course of this doing these knock knock eye, but we've gained more listeners and more followers and subscribers. And so I know a lot of people haven't heard some of that. So we'll do more trauma stuff like down the road. Maybe get back to some of those pants patients that we did right at the beginning of knock knock eye. But what I did do, I was like, okay, here's what I'll do. Maybe I'll just Google like the top 10 fireworks, like not the fireworks shows, like the top 10 things that people buy. Surprisingly, it was very hard to find that list. And I was just ended up finding like all these fireworks sellers and their top 10 list. So anyway, I found like it seems like a big fireworks store. Apparently you can buy fireworks online. Maybe it depends on the state you're in. That seems like a really bad idea to mail explosives. But regardless, there's a website I found, World Class Fireworks. Here's their top 10 fireworks. Let me just read you the names. And then what my idea was like, I could go through and like, what are the potential traumatic injuries to the eye that you could get from each of these? All right. So here's their top 10. This is just the names. Executioner. Show Me Your Kitties. The box has cute cats on the front of it. Neon Nightmare. Banana Bomb. One Bad Baby. Lone Star Lunatic. Knuckin' Futz. And Yippee Ki-Yay. Just a handful there. And I have come to the conclusion in reading the details of all of these and what they do, that the injury that these all would likely cause to the eye is a complete explosion. Just exploded eyeballs. So I realized that's probably not enough for like a full episode of Knock Knock Eye, because like that's really what it is. And some of the worst traumatic injuries I've seen are firework related. So anywhere from like the ones that actually shoot up and explode, and like people looking over the tube wondering what's taken so long. I tell you what, every time if you look in it, I can guarantee there's a 0% chance you as a normal person dabbling in fireworks will look into a tube that has a firework that you have lit the fuse on. There's a 0% chance you will look into that tube and come to any certain conclusion about why it has not fired yet. Only bad things can happen. So don't do it. I mean, I realize I'm telling you all this after 4th of July. Hopefully you didn't do it. And hopefully while you were lighting your fireworks and your sparklers that you were, and your Roman candle. Roman candles are the worst because people fight with those. They point them at each other and they shoot it. There's TikToks every year of this. People shoot Roman candles at each other, which when I was a kid, I would have thought that sounded really fun. But as a board certified ophthalmologist, horrifying. And so people get eye injuries from that. Sparklers is another one. You don't even think about it, but and again, I've seen a lot. I've seen too much. But my kids, if they ever, they did convince me to let them use sparklers this year. I'm very, very strict when it comes to fireworks. We can observe them from afar. Let someone else dabble in the explosives that hopefully has a background in those, has their diploma, certification in demolition. I don't know, whatever it is. And we're not going to do that. But sparklers, I have relented. We will do sparklers this year, but everybody will be wearing safety glasses. And that's the point. Safety glasses. Always, please wear safety glasses. And so real quick, before we get into the lens, I'll just mention open globe injuries, because that's probably one of the biggest things. Open globe injuries. Well, let's take a quick break. We'll come back and we'll do a quick. I'll do like no more than 5 minutes on open globe injuries.
Hey, Will.
Hey, what's up?
I've been thinking, the U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement. For
sure.
Sure.
It's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glockenflecken's really fun and super uplifting guide to American healthcare is out. And it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes. Okay. Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's right.
Really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glockenflecken.com/healthcare. Enjoy. Kristen, I got to tell you about a new podcast that every clinician should know about.
Ooh, tell me.
This is the Sepsis Spectrum.
Okay.
It's by the Sepsis Alliance and critical care educator Nicole Kupchik. This is really important. Each episode is about confronting blind spots in sepsis and antimicrobial resistance education. A lot of this stuff usually doesn't make it into textbooks or compliance training.
That's weird because it's super important.
Yeah, everybody needs to know about this stuff. You can listen to the Sepsis Spectrum wherever you get your podcast, or watch it on the Sepsis Alliance's YouTube channel. To learn about how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. All right, the dreaded open globe. The open globe is you have a rupture or a laceration of a part of the eyeball itself to where the eyeball is open. There is a direct connection to the juicy innards of the eye. Terrible way to describe it, and the outside, the air, the elements, and so when a patient comes in, here's just I could go on and on about open globes, but the most likely, especially with a blunt trauma, most likely locations for an open globe are going to be at the limbus, which I have my little trusty, because we're talking about some anatomy stuff today. So the limbus, if you're watching on YouTube, you can see me holding up this fake eyeball. It's a fake eyeball. Did you guys realize that? Fake eyeball. The limbus is right where the white part of the eye meets the cornea, right? That's the edge. That's the limbus. So that's actually one of the weakest points on the eye. So if you're going to have a rupture where you have a bad enough blunt trauma that you cause an open globe, it's going to be either right here I'm trying to do it through the screen. Right here on the limbus, or it's going to be underneath the extraocular muscles. Those are the two weakest points of the sclera, the wall of the eye. Obviously, a laceration to the eye can occur anywhere, but most likely it's going to be on anteriorly because that's the part of the eye that's most exposed. If a patient comes in after having a trauma, here's probably your biggest takeaway for all of you in emergency medicine or even urgent care, because I've seen open globes walk into urgent care. Here's the biggest thing. A patient who had a history of trauma who has no light perception. That means you shine a big ass light right in front of their eye. They cannot see that light in that eye. With a history of trauma, you have to assume that's an open globe until proven otherwise. Okay. Could also be a retrobulbar hemorrhage. All right. Chances are you're going to diagnose that pretty quick because the eye is going to be proptotic, going to be super swollen. You're going to see the proptosis on a CT scan, because chances are you'll have a CT scan by that point. Anyway, you have to be on high alert. No light perception, trauma, high alert for open globe, because there's very few things that can cause no light perception. Open globe is one of them, along with things like giant cell arteritis, angle closure glaucoma, bad chemical injuries potentially, retrobulbar hemorrhage, because you have a super high pressure that just blacks out the vision. Okay, so, and then I'm not going to go too much into treatment, but for a non-ophthalmologist, the treatment, once you've diagnosed the open globe, that's the hardest part, because it's just the same. You have the same protocol for every single open globe. All right. That patient's going to get 400 milligrams of IV moxiflox. Actually, no, sorry. Before I get to that, what's the first thing you do for an open globe? Put a shield on the eye. Because the last thing we need is someone with an open globe to start rubbing their eye. That's the fastest way for whatever still happens to be inside the eye to end up outside the eye, is if you rub an open globe. You'll rub the lens, the uvea, the vitreous, you'll rub it right out of the eye. That's not a good thing. You don't want to do that. All right. So put a shield on that eye right away. 400 milligrams of IV moxifloxacin, broad spectrum antibiotic that has excellent penetration to the eye and the inside of the eye. All right. So you'll cover a lot of nasty bugs with IV moxi. Nausea medicine, anti-nausea medicine. So Zofran, give them Zofran, because again, vomiting, nausea, it's going to increase pressure. They're going to, if someone's about to throw up, they increase their intra-abdominal pressure, which increases the blood pressure. You put pressure behind the eyes, and it can push. I've seen people push like the lens out of the eye because they have this Valsalva maneuver. They bear down either to lift something or they're throwing up. Make sure there's a CT scan. We got to be able to know if there's fractures, foreign bodies, something like that. And then just call your friendly neighborhood ophthalmologist and break the bad news to them that they got to come in and see a patient in the hospital, a place we dare not go unless we really have to. They'll come in with their little luggage. We love our luggage. I have some luggage that I bring when I come in, and I try to keep a low profile because most of the time people recognize me. But I'm also kind of tall and I have a very distinctive hair. And also every piece of content I've ever made is just the camera right in front of my freaking face. And so I have nobody to blame but myself for people recognizing me in the emergency room, which is fine. I don't mind. I get in some fun conversations sometimes. But anyway, and then we'll take the patient, usually open globe. You want to try to get that thing closed in the operating room, done, within like 4 hours. That's typically what we do. I forgot at the hospital where I used to do open globes. It was like a class B case. I don't know if that classification is uniform, but anyway, that's open globes. That's fireworks. Don't play with fireworks, folks. Let the professionals do it. I've seen too many terrible things. It's scarred me for life. And so now my kids suffer the consequences, and all of you for having to listen to traumatic eyeball injuries. I mean, we could go on and on about trauma. We could do hyphemas, 8-ball hyphemas, sclopitaria, retina commotio, retrobulbar hemorrhages. Various types of eyelid lacerations. These are all topics I have discussed before. If you want to hear them again, leave me a comment. Let me know. I'm happy to go back into it. I realize not everybody listens to every episode, so sometimes it's helpful just to hear things twice. I know when I was studying for boards, studying for everything in medical school, I was one of these repetition people. I would just like read books over and over again. I wasn't a highlighter. I'm not big on highlighting. But I would read and sometimes make mnemonics for myself, but mostly just go over things just time after time until I just had it in my brain, until I like forced myself to just encode that into my long-term memory. And I guess it worked for me. And so if that works for you, let me know, and I'll just keep repeating the same things over and over again. It makes it easy on me. Hey, I would love to do some of the same topics because I love them. They're great, but also you need a little bit of repetition from time to time, especially if you really want to learn this stuff. Okay, let's get into lenses. I'm so glad. I'm so glad that I got that comment from Embers Assembling 939 about running through ancient cataract surgeries. But before we get into the ancient cataract surgery, we'll go from like the earliest types of cataract surgery to what we do now. First, though, just a reminder of the anatomy. Okay, so I already talked about the limbus. I'm going to refer to the limbus a few times. All right, again, right where the white of the eye meets the cornea, which is that clear front covering. I'm tapping on it if you're watching on YouTube. A little cross section there. All right. If you go through the cornea, underneath the cornea, that's the anterior chamber. All right. About 200 microliters of fluid fills the anterior chamber. And then you hit the iris. We all know what the iris is, the colored part of the eye. Well, behind the iris is where your lens sits. All right, so when we do cataract surgery, we have to dilate the iris to get us access to the lens. So let's talk about the anatomy of the lens itself. All right, some of you may be familiar with my analogy of the peanut M&M, and it makes the most sense for how to visualize a human lens. And so you have your central nugget core of the lens. That's the nucleus. Now, the nucleus is not really that dense when you're born. You have cells that are constantly dividing. You get new epithelial cells that start at the equator of the lens, kind of the side of the lens. And as you're throughout the course of your life, you are constantly making new lens epithelial cells. They're long strips. You can think of it as kind of like an onion. And so each layer of the onion is kind of a long strip. That's a lens epithelial cell. And so your lens, over the course of your life, will make more and more lens epithelial cells. And as the new ones get made, they push the older lens epithelial cells like more toward the center of the lens. And they get compressed. They get compressed so much that it loses these cells, these lens epithelial cells, they lose all their organelles. They lose their nucleus. And they get super dense because they're so packed in there. And once you turn around 60, that nucleus starts to age so much that it turns yellow. It turns opaque. You can't see through it as well. It causes glare problems. And you have a cataract that's visually significant. So it's just those lens epithelial cells that over time, they get squashed until they form this dense, hard nucleus right in the center of the lens, which just so happens to be the center of your vision, right? You have to try to look right through it because when you're looking through someone's pupil, you're looking right through the center of their lens. So the peanut M&M is the candy shell is the capsule. So your cataract, or your lens, I should say your lens, sits inside a capsule. Okay? Inside the candy shell, the capsule, is the cortex. That's where all those epithelial cells live. All right? And then that's the chocolate inside the peanut M&M. And then the peanut, obviously, is the nucleus. Those are the three main layers of your lens: capsule, cortex, nucleus. Um, and really, the big thing that can go wrong with a lens is cataract formation. Now, there's different types of cataracts. All right, there's you can have a cataract where the cortex, the chocolate part, becomes opaque. You can have cataracts where the capsule becomes opaque. You can have cataracts just where the lens, the nucleus, becomes so dense and hard, and then it becomes opaque. You can actually have a such a dense cataract that's so old, if you wait so long, that the cortex can actually liquefy inside the capsule and the nucleus. It's called a Morgagnian cataract. The nucleus just kind of floats around in this lens epithelial soup. Pretty rare. I haven't seen a whole lot of those. Most of the time, people will have, in 2025, at least in the US, people will get cataract surgery well before it gets to that point. So, other things that can happen to the lens, it can, I guess another kind of anatomy is like, you might be asking, how does it sit there in the middle of your eye? Well, it's held up by strings that are called zonules. I've talked about the strings before. All right, this is like a scaffold, the little strings that prop that lens up in place right behind your iris. And whenever those strings, those zonules, which are made of collagen, whenever they are loose or you lose them, that can be as a result of trauma. It can be as a result of of diseases like homocystinuria or Marfan syndrome, or a type of glaucoma called pseudoexfoliation. You get loss of those strings, loss of those zonules, the lens becomes unstable, and it can undergo what's called subluxation, where normally those zonules that holds the lens perfectly in the center of the eye. But if you lose some of them, the lens might shift. And now it's not in the center of the eye. You might not even be looking through the lens. In that case, it's going to cause a severe vision loss, because if you're not looking through your lens, if you don't have a lens, then your eye is not strong enough to refract light. And you won't see it. You'll see like hand motion vision at best. So anyway, it's very important that your lens stays stationary right in the center of your eye. And for most people it is, unless you have a disease that causes damage to those zonules or you get hit hard enough. I have unfortunately had the good fortune to do cataract surgery on a few boxers. And boy, let me tell you, that's an adventure, because when you're doing cataract surgery, you need that lens to be stable because you're operating on it. If it's moving around every time you try to do something to the lens, it's either gonna fall into the back part of the eye. It's gonna become so loose you just can't operate on it, and so enough trauma to the head, you run that risk. That's no fun. So anyway, we got our lens stationary in the middle of the eye. So let's talk about how cataract surgery is done. Let's do that. Let's go through ancient history, and this is fun. So the earliest, I mean, for millennia, I'm sure just people just went blind from cataracts. You developed cataract, that was it. You couldn't see, and then dating around, I think the earliest time period we have for cataract surgery is around the 5th century BC. It was a technique that's called couching. So it comes from a French word meaning like to put to bed. And that's kind of what you're doing. You're putting the lens to bed. So what people did was they took a very, very sharp, very small needle, and they pierced the eye right at the limbus. Remember, I'm telling you about the limbus. So they'd go in. This is actually smart that they didn't go right in the center of your cornea, because you got to look through the cornea. So they would go through the edge of the cornea, right at the limbus where the white touches the cornea. And they would manually push down on the lens to push it into the back part of the eye. So what they're doing, because remember, what's keeping the lens there? those zonules. So what they're doing is when you couch something, you're breaking all of those strings, all of those zonules. That entire scaffold just gets severed with the pressure of pushing down the lens. And so whereas some diseases, as I mentioned, will cause subluxation, the lens will move. Well, couching, you're doing that on purpose. You might be like, why would they do that? Well, because at that point, that person has a cataract that's so dense, they cannot see anything. They're either light perception or no light perception. By moving that dense cataract out of the visual axis, then you at least allow light to come in through the cornea and reach the retina, which you weren't able to do before because this patient had a massive cataract that was so dense, no light was getting into the eye. Well, now you got light coming into the eye so people can see shadows. People can potentially, depending on how myopic they are, they might actually have like useful vision, being able to see a hand moving in front of their face, maybe even counting fingers. Like, we're talking going from no light perception to at least seeing shapes and hands and faces. Probably can't see detail with the faces, but just faces nonetheless. So anyway, that was all they had. That was all they had. Now, unfortunately, this procedure would have short-term effects because when you do that to the eye, it causes a dramatic amount of inflammation that the eye just won't be able to survive. And so you'll end up with glaucoma. You'll end up with retinal detachments. You'll end up with inflammation and damage to the optic nerve. You will eventually go blind. But this was usually done very late in the person's life, and they might get a few weeks of useful vision before they go blind. And unfortunately, it was probably kind of painful too to the eye. But you could look at it one way and say, well, they were blind anyway to begin with. And so they got a few weeks of good vision. And that's what we did. That's what it was until as early as we have some texts that suggest around 600 BC, people were trying out cataract surgery in a slightly different way, where you leave the capsule in place. So I talked about the capsule, the candy shell. You leave that capsule in place and just take the cataract out of the capsule. Now, we're not talking about artificial lenses yet. We have not gotten there. But once people started, and really it wasn't until like the 1700s where the primitive versions of this really took hold. So it was couching from like 5th century BC all the way up to like the 1700s. The French surgeon Jacques Daviel is credited as the father of modern cataract extraction surgery. What he would do, and this is the way it was done right at the beginning, was making a 10 millimeter incision with a knife. Now, you might think that is a very small incision, but when you're talking about the cornea, it is massive. That is like almost half the cornea. You're cutting into, you're making that giant incision. Just to give you a frame of reference, now we do incisions that are about like 2.5 millimeters. So much larger. Let's take a break before we go keep going further with extracapsular cataract extraction.
What you doing there, buddy?
I'm so glad you asked.
Oh.
I'm being a Demodex.
Oh, are you?
Yeah, that's what they sound like.
Those little mites?
Uh-huh. If you put a microphone in front of them, I'm sure they would probably, most likely, maybe sound like that.
You think so?
I don't really know.
Oh, well, let's see how much you do really know.
Oh, you're going to quiz me?
Yeah.
Let's do it.
What are the only two main species of Demodex mites found in humans?
Type 1 and type 2.
Close. Demodex follicularum, which are found in the eyelash follicles,
Okay.
and Demodex brevis, which are found in the meibomian glands.
Okay, sure. Yeah. Okay, next one. Next question.
Okay. Why do people with Demodex blufferitis often feel itchy eyelids first thing in the morning?
I know this, and because they avoid light and come out at night to mate.
Oh.
Yeah, they're mating on your eyelids while you're sleeping.
Super.
How does that make you feel?
So gross.
And so people wake up with that itchy, irritated feeling because they've been moving around on the eyelash follicles all night.
Mm-hmm.
Yeah.
Yeah. great.
I'm surprised you even brought that up.
I know. I'm just trying to get used to these mites since Demodex blufferitis is such a common disease and
It
we keep talking
is,
about them.
and that's a big step. That's a big
Thank
step.
you.
There's a prescription eye drop, though, that's available for Demodex blepharitis. Did you know that?
Yes.
To learn more about these mites and Demodex blepharitis, visit miteslovelids.com for more info. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, so we are in the 1700s, and this French guy, this great surgeon, he's making a giant incision on the cornea, and he's opening the capsule, that candy shell of the lens, and he's just using a little spatula, like a little curette, and he's scooping out the cataract. He's scooping it out. And then they would just get out as much as they could through that incision. They would put little tiny sutures through that incision, and that was it. They just leave it. Now, unfortunately, this was a big advancement because it was less inflammatory than just pushing the lens into the back of the eye. But still, these eyes did not do very well. So they maybe had got improved vision for a little bit longer than couching. But not much longer because they still, they'd end up with wound leaks. They'd end up with hypotony where you have low eye pressure. They had no way of controlling inflammation in the eye from just having an intraocular surgery. But it did last a little bit longer. Unfortunately, they still didn't have a way to improve vision beyond just removing the cataract. Right? We had no intraocular lenses like we do now. All right, so this was, 1750s that this was going on. And then it wasn't until World War II that we figured out we could put an artificial lens inside the eye. And this is one of my favorite stories. This is a story like every ophthalmologist knows this story about Dr. Ridley of the Royal Air Force in Britain. And Sir Harold Ridley was a physician, and what he found was that some pilots who were shot at in their cockpit, they had a couple of pilots that would have pieces of the cockpit glass embed in just throughout their face, right? Because they're getting shot at, but specifically in the eye. And what he found was that as opposed to like metal shrapnel, this cockpit material, which was made out of a plastic called PMMA, is a very, very hard plastic, polymethyl methacrylate, I think, polymethyl methacrylate. As opposed to metal, like iron, copper, which causes an explosive inflammatory reaction inside the eye, this PMMA, it was inert. Like some of it would get in the patient's eye, but then not incite an inflammatory reaction. And so he was smart, this Calvin Ridley. Did I say Calvin Ridley? Calvin Ridley's the football player. Sir Harold Ridley, it was brilliant because he was like, wait a second. Maybe we can use this as an artificial lens inside the eye. We can shape it to where it's like a contact, it's like a magnifying lens. And you put it in the eye and voila, maybe you have better vision. And it worked. It worked. And so that was the birth of using artificial lenses. They were made for a long time. They were made out of PMMA. Now the downside is that's a very hard plastic. So it's not foldable. So you still had to have big incisions. Now they weren't 10 millimeters for long because that's a tough incision. So they got down to like maybe 6 millimeters, which is still a massive incision by today's standards. Because you couldn't fold up a lens and inject it through a small incision. So you had to have this big incision and put the lens in whole. And what they were doing is they would do where they puncture the capsule, they would scoop out the cataract, and then they would put that artificial lens in the capsule. And that's kind of the way we did it until around like the 1970s, which is when we started to develop the first foldable lenses, which were great because it allowed us to insert these lenses through a much smaller incision. And if you can do a smaller incision, you're going to decrease the risk of infection. You're going to reduce the amount of astigmatism that you cause as a result of the surgery. The cornea is just less operated on, which is great. So you won't have as much astigmatism after the surgery. Faster healing time. Suddenly, we didn't have to admit patients to the hospital for 5 days with sandbags next to their face until they healed up enough to be released from the hospital. We started being able to do outpatient surgery starting in like the 1980s. And so we were doing smaller incisions, different types of lenses. We could change the power of the lenses now. And so at the first iterations of these intraocular lenses, they're just one power. So no matter what, whether you had a 30 millimeter eye or a 22 millimeter eye or an 18 millimeter eye, everyone got the same lens. You just kind of dealt with it. You just knew you were going to get glasses after surgery, and they might be still really strong glasses. You might still be a -8, -9, +3, +4. As opposed to now, where the expectation, we have innovated cataract surgery to the point where people expect perfect 20/15 vision, which can be really hard expectations to meet as a cataract surgeon, I will tell you. That's why I do miss those farmers from Iowa, because if they just came out of surgery with 2 eyeballs, they were great. They were very happy. So now we're doing our more of a modern small incision cataract surgery. And then over the years, we've added different types of intraocular lenses. Now we have these light adjustable lenses where you can put the lens in the eye and then you can reshape it based on what the patient's post-op refraction is. We have laser assisted, femtosecond laser assisted cataract surgery, which some people really like. Although we don't have really strong evidence to suggest it actually improves outcomes. So my practice, we don't use it. We did for a while, realized, there wasn't enough people like interested in using it, so we don't use it anymore. People still come and ask about, do we use a laser? Well, even if you use a laser, by the way, you guys, even if your surgeon uses a laser, they're still manually removing that lens. Like, we don't have a laser or a robot yet that will do that for you. People are working on that. Why? I have no idea, because, man, we have innovated cataract surgery to the point where we can do it 5 minutes. We can do a cataract surgery. So it's pretty remarkable where we've come with cataract surgery. It's still probably the area, along with retina and glaucoma, where there's the most innovation happening. It's like every year there's different types of lens technology. We could talk for hours about different lens technologies. For those of you who are not in ophthalmology, I can't imagine how boring that would be. So we will stop there. Human lens, cataract, anatomy, a little bit of embryology, and my favorite part of the eye. If you have any questions, please send them to me. You can email me, knockknockhi@human-content.com, or you can just go to the YouTube channel, @Glaucomfleckens. I didn't do a lot of Q&A this time. I usually do a few more questions. I'll get to that next time. But leave a question. I always look at those comments. Thank you all for following, for subscribing, for listening. I do this for you guys. I love teaching you guys about eyeball stuff. And so thanks for sticking around. Thanks for listening. I'm your host, Will Flannery, also known as Dr. Glaucomflecken. Thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brick. Editor, engineers, Jason Portiza. Our music is by Omer Binsby. We'll see you next time. Take care of your eyeballs.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.